Welcome to The Explainer. I'm absolutely thrilled you're tuning in today because we're going to tackle a topic that is just as incredibly complex as it is fascinating: multiple sclerosis. For the longest time, MS has been this profound medical mystery. It's a disease that literally rewires the central nervous system. But the recent breakthroughs we've made in understanding exactly how this disease progresses, and more importantly, how we can actually stop it, have completely transformed the landscape. So today, we're going to break down the latest science, taking you all the way from the microscopic battlegrounds inside the brain straight through to modern, highly effective therapies.
Here's a quick look at our roadmap for today. We'll start with the anatomy of demyelination, then move into mapping the clinical courses. After that, we're unmasking silent progression, looking at how we diagnose multiple sclerosis, and finally, we'll wrap up with disease-modifying therapies.
All right, let's dive right in. Section 1. The anatomy of demyelination.
To really understand MS, we have to start with a fundamental biological error. Think about this for a second. What actually happens when the body's most elite defenders, your immune system, mistakenly identify your own tissue as a foreign invader? Well, in MS, the primary target of this biological-friendly fire is myelin. That's the vital protective insulation wrapping around our nerve fibers.
So let's look at how this pathogenesis actually unfolds on a cellular level. First, you have these inflammatory mononuclear cells, specifically T cells and macrophages, and they infiltrate the central nervous system. To even get in there, they have to disrupt the blood-brain barrier, effectively breaching the perimeter. Once they're inside, these immune cells, along with B lymphocytes and autoantibodies, just start orchestrating the destruction of the myelin sheath. It's kind of like the rubber insulation around a copper electrical wire. If you strip that protective insulation away, the electrical signal just shorts out, it slows down, or it stops completely.
And that brings us to the crucial point of what happens next. This loss of insulation creates a phenomenon that neurologists call a conduction block. Basically, the action potentials, the brain's electrical signals, fail to propagate down the damaged axon. But here is a truly fascinating real-world clinical correlate. This conduction block often worsens with exposure to heat or exercise. This means a microscopic cellular event translates directly into physical symptoms that can fluctuate literally just based on the temperature of the room.
Let's shift gears a bit. Section 2. Mapping the clinical courses.
MS isn't just one monolithic disease path. It has very distinct clinical phenotypes. About 90% of cases actually begin as relapsing remitting MS, or RRMS. This one is characterized by discrete, sudden attacks of neurologic dysfunction, which are then followed by periods of recovery. Over time, RRMS often transitions into secondary progressive MS, where patients experience a more gradual, progressive deterioration that happens independent of those acute attacks. But then we have primary progressive MS, which accounts for about 10% of cases. Unlike the relapsing form, PPMS patients experience a steady decline right from the onset. And here's an interesting demographic split. While relapsing MS heavily skews female and starts earlier in life, PPMS usually begins a bit later, like around age 40, and has a much more even male-to-female ratio. We also categorize patients who steadily progress but still have acute attacks or new MRI lesions as having active progressive MS. And really quickly, it's also worth noting there are some very rare, highly aggressive variants of the disease, like Marburg, tumefactive MS, and Bellow's concentric sclerosis. These feature some really unique, atypical lesion patterns and, unfortunately, rapid clinical declines.
Now, if you look at this visualization of the disease continuum, notice the shifting dynamics here. Early on, you see this massive spike in neuroinflammation. Those represent the clinical relapses and new lesions. But underlying that, right from the very beginning, is a steadily rising curve of neurodegeneration. For a long time, the medical community thought of the relapsing phase and the progressive phase as two entirely different diseases. But the modern view recognizes that inflammation and degeneration actually overlap and evolve together over the patient's entire lifetime.
This overlaps perfectly with our next topic. Section 3. Unmasking silent progression. We really need to talk about how patients actually accumulate permanent disability. Historically, the entire focus was on RAV, relapse-associated worsening. So a patient has a severe attack, they don't fully recover, and they're left with a deficit. It's visible, it's obvious, right? But juxtapose that with PIRA, progression independent of relapse activity. This is the stealthy thief of MS. Disability accumulates from that underlying neurodegeneration we just saw in the graph, but it happens completely without any acute clinical relapse. The patient isn't having sudden attacks, but their baseline function is slowly, quietly slipping away in the background.
I want to highlight this quote directly from our source material because it genuinely changes everything.
It is now clear that PIRA is the cause of disability accumulation in RRMS, SPMS, and PPMS. This silent progression happens so insidiously that neither the patient nor their provider might even recognize it at the time. A patient might think they're doing fantastic because they haven't had a relapse in 3 years, but if you look closely, maybe their walking distance has slowly halved. This realization has fundamentally challenged the old strategy of just waiting around to treat until the next big relapse happens.
So how do we actually spot this disease? Let's get into Section 4, Diagnosing Multiple Sclerosis.
The absolute gold standard for diagnosing MS is the McDonald criteria, and it really boils down to proving two core concepts: dissemination in space and dissemination in time. Dissemination in space just means proving the immune system is attacking multiple different zip codes in the nervous system. We need to see lesions in at least 2 of 4 classic MS regions. So places like around the ventricles, near the cortex, in the lower brain, or down in the spinal cord. Dissemination in time, on the other hand, means proving these attacks didn't just happen all at once in a single fluke event. We're looking for a mix of old, healed lesions sitting right alongside new, actively enhancing lesions on an MRI. Or we simply wait and spot a brand new lesion on a follow-up scan down the road.
But we don't just rely on imaging. We also analyze the cerebrospinal fluid. We look for something called oligoclonal bands. Basically, what this means is that the body is churning out specific antibody clones right there inside the central nervous system, which proves there's localized inflammation. Finding 2 or more of these discrete bands in the spinal fluid while they're noticeably absent in the blood serum is a massive diagnostic clue. In fact, these bands are found in over 90% of MS patients.
Speaking of massive diagnostic clues, let's talk about neuroimaging. A classic, highly specific MRI hallmark of MS is the presence of Dawson fingers. These are very distinct, finger-like lesions oriented perpendicular to the brain's ventricles. Also, with modern high-resolution MRIs, we often see what's called the central vein sign. This literally shows a small vein running directly through the center of these lesions, which is incredibly helpful for neurologists trying to separate MS from other demyelinating diseases.
And now for the really optimistic part of our explainer. Section 5, Disease-Modifying Therapies. Let's organize the heavy hitters of modern therapeutics so we don't just get completely lost in a sea of pharmaceutical names. Notice how we've grouped them by their mechanism of action. Right at the top, we have the anti-CD20 monoclonal antibodies, drugs like ocrelizumab. These are high-efficacy treatments that specifically target and deplete the problematic B cells, driving the inflammation. Next up, we have cell trafficking inhibitors, like natalizumab. These literally block immune cells from crossing that blood-brain barrier we talked about earlier. It is incredibly effective, though it's typically reserved for patients who test negative for the JC virus due to some specific safety risks. And finally, we have oral options like S1P modulators. These work by actually trapping lymphocytes in the lymph nodes, so they can't ever reach the brain, making them fantastic options even for patients dealing with active secondary progressive MS. Because we have these powerful mechanisms at our disposal, the modern treatment paradigm has shifted radically. Today, neurologists strongly favor hitting the disease hard and early with these high-efficacy therapies right out of the gate. Why? Well, because as we learned earlier, we aren't just trying to stop the visible relapses anymore. We have to stop that silent thief, PIRA. Early deployment of drugs like the anti-CD20s provides outstanding control against those clinical attacks, offers maximum protection against silent underlying neurodegeneration, and, crucially, they manage to maintain a highly favorable safety profile over time. We have journeyed all the way from the microscopic infiltration of immune cells out to the broader clinical phenotypes, and finally, to the incredible power of modern therapeutics hitting this disease hard and early. But I want to leave you with one final provocative thought to chew on. If identifying that insidious silent progression early is the absolute key to preventing long-term disability, how is the next generation of diagnostics going to completely change our timeline for therapeutic intervention? Just imagine a world where we could detect and stop PIRA before a patient even realizes their baseline has shifted. The future of MS care is moving at lightning speed, and the battle against this complex disease is one we are actually starting to win. Thank you so much for learning with me today on this explainer. Keep questioning, keep learning. I'll catch you on the next one.